Hi, good morning, everyone. Thanks for joining the Zoom sessions. Sorry, I can't use the Microsoft Team because I'm not added. So anyway, we have 1 hour to go through the polypharmacy lectures today. So something very close to my heart and also very relevant to your practice later on as a prescriber. So let me share the slides now. Okay, so hope you can hear and see my slides clearly. If you have any questions, feel free to open your audio, okay? And I'll be sharing the slides and also additional readings. For these lectures, it will not be tested in your exam, okay? Mainly just for general knowledge, good for you. You're bound to have this polypharmacy lecture again during your clinical years. This is a very clinical pharmacology topics, one of very highly regarded now because also the importance of geriatric medicines and also, or we call it older adult. There's a lot of research going on how to help the older adult to adhere to their medications. One thing is through de-prescribing. So you have polypharmacy, and also another side of the coin is the de-prescribing, DE. So, okay. For the next 50 minutes or so, we're going to go through what is polypharmacy, issues related to it, and its implication, not just on the healthcare, on the cost also, because you unnecessary prescribing, what it should be, okay? Okay, I would like you to take 1 minute to go through these two lists of or this list of prescriptions issues since 2016 until 2017. Okay, this is before implementations of Brew Health. With Brew Health, this thing can be overcome because the prescribing list is synchronized between health clinic and also the hospital, but not with the private one. So if a patients go to a private GP's clinic, the doctors at the clinic or GPs would not know what is being prescribed by the MOH doctor unless the patient show their Brew Health, okay? So from all these lists of medications, you can also think of what kind of the disease or the diagnosis. Okay, we're going to revisit this one later on at the end of today's discussions. Mainly, as you can see here, on the 17th of December, one doctor prescribes paracetamol and orphanadrines as a muscle relaxant and also analgesics. Most likely, these patients went to a orthopedic or at the outpatients to get treatments because of the sprained muscles or general pain. And then this is the full medication list prescribed most likely by the cardiologist, okay? This one is for prescribed for how many days? 233 days. This one's for 30 days, okay, 90 days. And then someone else prescribed vitamin D, someone else prescribed psyllium because of the constipations. Okay, so this is another prescriptions being issued by probably by the gastroenterologist. Okay. So there is this thing is overlap of prescribing, and at the end it manifests or it categorized under clinical pharmacology as a polypharmacy. Okay. What is the polypharmacy means is you can guess from the name. Poly is more than one, multiple. Pharmacy is the prescriptions, okay, more than all the medicines. Okay, prescriptions or prescribing of multiple medications, often in the same mode of actions, okay, or same mechanism of actions and similar class. For example, antihypertensive, okay, you have antihistamine or antifungal. Okay, so it's not necessary to be inappropriate, but that's why we need to see the context in the following slides. Okay, often it reflect of miscommunication or inappropriate communication with the prescriber, with the patient. Sometimes the patient also concealing informations because they do window doctor hopping or doctor shopping or pharmacy shopping, whatever you can call it, meaning that they purposely go to see different doctors. Sometimes it's for second opinions, but then each time when they see the doctors, then the doctors tend to prescribe something as this is become a tradition now, because that what the patients expect from the prescriber itself. It's like, oh, how come, why you didn't give me any medication? It's like, as the mindset is, I go to see doctors, doctor will prescribe me something, or I go to see pharmacy, the pharmacist, they have to sell me something. Okay, if not, then they go out like empty-handed, like, oh, how come I didn't get anything? The doctor don't care about me. Why didn't prescribe me any medications? Okay. Sometimes the prescribing, and when it's called polypharmacy, that means it is the negative connotation. Okay, the positive one is we use it the same class with a lower dosage for the synergistic effect. Okay, maybe you use more than one antihypertensive agents to with the different mechanism actions. Okay, you have the beta blocker, you have the calcium channel blockers. Okay, I will show more example later. Okay, so I would like to highlight as well, with the passage of times, often now there's another definition surface. Another definition for polypharmacy is when the patient they're using more than 4 or 5 medications. Also, this also called polypharmacy. But for this lecture purpose, we are talking about using a medication in the same class, which is inappropriately. Okay. So if we put in a Google polypharmacy, this definition will pop up, which is not the main discussion for today. Okay. This is quite often now. If you see any of your aunt or even for those who more than 50 years old, if they have comorbidities or hypertension and diabetic, which is one of the most common non-communicable disease in Brunei or globally, okay, they're bound to have more than 5 medications. This include their multivitamins, health supplements, and also herbal medications. Okay. So because the doctors prescribe it for more than one the conditions they might be having, as I mentioned, they could have osteoporosis, they could have gastric reflux, which is quite often. I as well have gastric reflux. They can have any other eye drops for their glaucoma, for their dry eyes. Okay. So as I mentioned, this polypharmacy have a negative connotation. It means the inappropriate prescribing or poor prescribing often is intentional. Okay. So when you have polypharmacy, then you will have to consider de-prescribing, reducing the number of medications, especially to enhance compliance or adherence so that they can easier for them to manage their medication, especially for geriatric patients, or the common terms now we like to use older adult rather than call them as a geriatric, or we call it sometimes we call it vulgar mass in local setting. So there is exceptional cases where polypharmacy is allowed, okay, or we call it the is still appropriate, especially someone have a multiple organ disease or multiple organ failure, which they need more than multiple medications, even sometimes in the same class. Okay, like for example, those who have kidney disease, it's very hard to bring down their blood pressures. Sometimes they will be taking ACE inhibitors and ARB. Okay, we tend not to prescribe ACE inhibitors or angiotensin receptor blockers together, but for this kind of patients with a kidney disease, sometimes it's warranted. Okay, and it's recommended by the guideline as well. Adjunctive treatments, okay, for some certain disease, for example, those who have dementia, or those who have for example, on chemotherapies. Okay, not when the symptom is not well controlled by one medicines, and if we can fully assure that the patient is taking their medications or fully compliant or fully adhered to their medication, because a lot of time is your patient is already on one medications, but prescribed one medication, but the patient is not taking it. Either they suffer from the side effect, or sometimes it's just that they are not fully convinced they should take that medications, but they didn't inform the prescriber or didn't inform the pharmacist. Okay. So another option is there's a good supportive evidence to give multiple drugs, as I mentioned, if your patient is on the antihypertensive. But when you are prescribed more than one antihypertensive, it is on the different mode of mechanism action. You will not give two beta blocker together. Okay. So this one, just to give you an overview, we can talk, it can be a one module itself on the polypharmacy or prescribing. Okay, so you are still in year 3. So when you are in the clinical year, it opens up more opportunities for learning when it comes to prescribing or learning about further clinical pharmacology. Okay. So when talking about appropriate polypharmacy, then you're talking about the therapeutic objective of why you are prescribing it. And also it has to see from a case-to-case basis. A lot of guidelines, also textbooks, which later on, if you want to do further reading, I'll provide you some very good case report. Okay. So why we are using more than one medication, sometimes in the same class, to reduce the adverse drug reactions. The most commonly used example is the antihistamines. Okay, you sometimes dermatologists, they will prescribe the first generations antihistamine for the nighttime use. Okay, for example, your Piriton chlorpheniramine, one tablet 4 milligram because it helps patients to sleep better, because the side effect is it can cause drowsiness. And then they will prescribe the second generations, a newer antihistamine, for example, loratadine, during the daytime, so that the patients still can function, operating machine, driving, working during the daytime. Okay, so this is considered as an appropriate polypharmacy. So in that way, it can enhance the patient's adherence, because patients empowered, they know why they're taking it. Okay, if not, the patient will tend to Google themselves. They say, oh, why I'm taking 2 antihistamine at the same time. So, but by rationalizing it, okay, the patient will be motivated to adhere to this means prescribed medications or prescribed regimen. So what caused this polypharmacy is a chicken egg problem. Often it's not because of the prescriber, it's the demand by the patient itself. Okay, they want patient to prescribe more, or they go to see different doctors, okay, or they see at the private, they went to JPMC, and then they went to a Ministry Health facilities. Okay, let's go through some of the causes for polypharmacy, and also this is for us contentions to think and ponder upon whether as a prescriber, do you have to please the patients, or sometimes we prescribe for ours, we prescribe, not treating the patients, but we are treating the patient's demand, okay, in the sense that we wish to please the patients by putting on more medications to them, or sometimes just to please the sales rep. This is something that there is a component of conflict of interest in terms of medical ethics that we were going to discuss later. Okay, sometimes of the workload itself doesn't allow the prescriber to talk to or spend more time to the patient to talk about what kind of a prescription they are having. Okay, are they having prescriptions from other GPs or private facilities? The easiest one, then they just prescribe. Okay, but sometimes you just need to get the message across to the patients that, okay, whenever medication that you have, please return to the pharmacy or don't use it, okay, or bring it to the medical clinic next time, so that they can help to sort it out. They can do medication reconciliations, which is another activities often carried out by the pharmacy teams, so that they will go through all their medications, okay, with their patients, because this medicine holding is an issue. Okay, often or not, it leads to medication wastage. So in Ministry of Health, we have done studies. This medication wastage is multiple million per year of patients not using the medication prescribed to them. You see that you go to anyone's house, you see that in their medicine cabinets full of medication, because each time when they see doctors, they will prescribe medications, and then they just collect it as fee. They see this is what as a good patient should do, but they are not taking it, or lead to a lot of medication wastage. Okay, so this is what the prescriber that you can do to help to reduce this wastage. Okay, patients not seen, this is what I mean. Okay, as a whole, holistically, the cardiologist will prescribe their medications, the endocrinologist prescribe their medications, but thanks to Blue Health, this thing can be addressed now, because they cannot prescribe, or they get to know what is the medication was already prescribed by the other department. Okay, and another issue is if the prescriber prescribe the medications based on the previous RX or previous prescriptions. So that's what the case that I presented just now, and instead of asking patient, or do you really need the cortisone, is your gout is controlled, rather than is it hyperuricemia or is it gout? Okay, there's some difference if it's a treatment for gout and hyperuricemia. Often, even though in gout you will see hyperuricemia. Okay. Another one is, as mentioned, we are pleasing the patient because it's their demands, or it's convenience, or sometimes it's because they would like to, it is a psychosocial problem because they like to, like the hypochondriac, they keep on seeing doctors, and we cannot deny them their right to see or to get treatment, because we cannot say, hey, you just came 2 days ago. When they come to the outpatient, they still have to enroll them or give them an appointment to see doctors, and then they will demand, oh, I want this medication, prescribe me this medication, please. So, but I think, I see with a newer, the attitude slowly change. They will not want to prescribe medications, and there is a directive also given by the Ministry of Health to do de-prescribing, which is a good thing. Okay. Promotion, self-representative, this is you bound to see also when you're doing your clinical years overseas. This is, for example, there will be like the sales medical representative, they would tend to detailing. The word is the detailing, meanings that they're telling, oh, you know, this new antibiotic is really good from the clinical study, it shows this. So they keep on pushing the prescribers to prescribe their medications. Okay, this is a bit quite controversial. Like, for example, JAMA say that, okay, the prescriber will tend to prescribe medication because the medical rep will bring them some lunches, or bring them out for lunch, or give them some, or buy them lunch or take away, which is in returns they feel like, oh, I'm bound to help the prescriber, that he's a good guy, she's a good guy, I want to help him to hit the sales target. So naturally, then they will increase the tendency to prescribe more medication, particularly those carried by the medical reps, sales rep. So this was my previous study done looking at the review of papers on the medical inducement, meaning that the medical sales representative, pharmaceutical representative, they will see doctors to push the doctors to increase this prescribing, so that directly the sales will increase. Okay, so let's look at the conclusion together. Okay, often the physicians will refer to the medical or pharmaceutical representative as a convenience way of getting medical information. Okay, and the physician also very willing to meet them often or not, just as a friends, or not necessary which for the kickback or for the gift. The gift can come in all ways, different kind of ways. For example, attending conference locally or overseas, or attending the continuous medical educations training. Okay, so this is the scenario, or this medical ethics. It's hard to address because this is often being somehow accepted, like, oh, it is okay for a medical representative to sponsor your trip overseas to attend a conference. Okay, so when you become a fully registered medical practitioners, then you get to know what I'm talking about. This is also in overseas, you had to declare if the conflict of interest, like are you being sponsored or being paid as a consultant for the for example, by Pfizer or Novartis or the big pharma company to provide talks or become a speakers, okay, or are you holding any shares of all these big pharma company, because it is a conflict of interest, because indirectly by pushing the sales up, okay, not just by you, by the whole medical teams, at the end it will help to increase the share prices of the company. I know in Brunei we don't have a stock exchange, but in overseas, for example, especially in the bigger countries, UK or US, this is whenever the physicians, they give talk, they have to declare that, or are they directly sponsored by all these big pharma company. So these declarations have to be made. So if you would like to read more about medical ethics, I'll share all this, including my paper with you on the drug promotions, either in a good way or in the negative way. Okay. Okay, let's come back to polypharmacy. What are the other causes of polypharmacy from the prescriber? Just now we learned from the patient itself. Now also it boils down to the knowledge and education of the prescriber, patients, and allied health professionals, for example, dentists, which also they can prescribe. Okay. In some certain country also, the pharmacists, they can prescribe. In Brunei, the nurse, they can prescribe medications also. Okay, so it's allowed by law. So they need to know what kind of medications patient already have, rather than keep on adding more medications, because often the patient will not know. It comes with a different brand name. Okay, for example, the omeprazole, it can come from manufacturer A, it can come from the original manufacturers by the AstraZeneca. Okay, lost that the brand name. Often also prescribing using brand name would not be able to detect the polypharmacy, because if you prescribe as a Losec, and then it is, even though it's omeprazole, in the private clinic especially, the dispenser, which often they are not trained, because the dispenser at the clinic or the GP, they are not even properly trained. They are not even having any certificate in the in pharmacy, or so they are often is just an all-level graduate, so they will not differentiate, or when they prescribe the Losec, which is omeprazole, and also omeprazole given as a generic name. Okay, this is again what I've highlighted. It is from the demand and expectation from the patient itself when they do doctor hopping or doctor shopping. Okay, seeing different doctors. Okay, and also promotion or drug promotions by the medical representative, because let's say now I am the medical representative or pharmaceutical representative of let's say Pfizer, and then obviously my job scope is to help the doctors to understand about what kind of medication. Let's say now I am in charge of under my, because they have for example medical rep in charge of let's say amlodipine, or the trade name is Novas, which is by Pfizer. So my role as a medical representative of Novas amlodipine, I need to go to see doctors, pharmacists to tell them, okay, now Novas 10 milligram, the new indications just for patients with hypertension. It is also can be prescribed for those hypertensions or with, let's say, for example, kidney failure. So my role is as a medical representative is to educate the doctors. Okay, indirectly I'm pushing the prescriber to prescribe more of the drug in charge by me. Okay, how from the pressure from the friends and family members, for example, oh, I'm taking this medication, it's good, my blood pressures go down, control very well with this Novas. Okay, and then when next time when they see doctors, oh, can you please prescribe me Novas, please? But most likely patient is already on amlodipine. Okay, so this amlodipine now is the first line of antihypertensive drug. Okay, media, thankfully, here in Brunei, medicine advertising is not allowed. Okay, but in Australia, UK, the drug company, they can sponsor advertisement on the TV or on radio. Okay, so it somehow induce patients to tell the doctor, oh, I want these medications, please prescribe for me. Okay, and another common example is the prescribing of the junior doctor often follows the medical officers. Okay, this is based on eminence rather than evidence. Okay, why you prescribe this medication? Or I just follow the previous the MO or prescribing, so I just continue. Okay, so you need to ask yourself, is there any evidence or not? Because now we are talking about evidence-based medicine. Okay, we are looking at the systematic review or meta-analysis. Is it really helpful? These medications to the patients, especially looking at a very subset, okay, with a kidney failure or with diabetes. Okay, so it become very advanced now. You can just use your phone to check all these databases, which can feed you with a lot of good recommendations. Or you can call up the pharmacist to look for the evidence for you. Work environment also understaffed. You don't really have time to go through the medication history. Poor documentation now is overcome now with Blue Health. Okay, poor connectivity of care. Like say, for example, patients is being referred by from JPMC. So the JPMC doctor, they should provide a very good prescriptions and also history of medication history, so that with the prescriber at the Repast hospital, for example, they will be able to prescribe rationally. Okay, times. Okay, this is, for example, patients want to discharge today, and then you need to give them the discharge summary and also discharge medications, because they will do the bedside dispensing. So you have so many patients at one time that you need to discharge, okay. So after ward round, you only have a window of 1 hour to sort out all their discharge medications. So this is the time constraint is one thing, okay, which is at one times you need it is okay, quite hard to overcome unless you come in early, very early morning, okay, to go through with them, because you know that, okay, this today we're going to discharge all these 5 patients, so you very quickly go through their medication already. But in a way, as a team, you can also invite the pharmacist to come in to do the medication reconciliation with you, so that they can feed you, okay, doctor, this is what the medications that you only should prescribe, because patient is already having all these medication on their own or from the JPMC, or they already are getting their medications from overseas. Okay. What is the implications, direct implications on the patient itself, because they are the one who is the user, they are the one taking the medications. Okay, their body is the one who at the end receiving all these medications. Okay. It can cause, first of all, psychological aspect, confusions and poor understanding, because they do not know, just like what the first picture shows, this older adult facing all this medication, they don't know how to manage it. Okay. Change of medications often is change of the brand. This is very important also. We try to stick to one brand, especially very narrow therapeutic drugs, for example, anticoagulant, warfarin, digoxins. Even though warfarin 3 milligram from different manufacturer will give you different IMR levels. So this we call it therapeutic equivalence. It is not guaranteed, even though it is bioequivalence, BE bioequivalence, and on the other hand, you have therapeutic equivalence. Okay. Change in dosage regime, for example, just now the endodipine, when they start, it's 2.5 milligram, and then often based on the patient response, they will increase the dose slowly, okay, to prevent patient having hypertension. Then start and then go for 5 milligrams. At the same time, you have the de-escalations of, for example, patients is on the steroid as an anti-inflammatories for the rheumatoid arthritis. So the dexamethasone steroid should be, for example, from the high dose 10 milligrams, slowly change to, or 2 tablets a day, change to 1 tablet, okay, after a day, after 1 week. So this thing need a lot of education. Okay, if not properly prescribed, patient might be continue buying it from the either from the GPs, and then the GP will prescribe different GPs. They would not know, actually they already should be the escalate their steroid. Okay, so it lead to poor adherence also. This one is the scenario as I can be also, patients is prescribed with multiple medication, but they are not taking it. So the assumption is HYBP is still high. Okay, add on one more agent. Okay. Poor continuity of care. This is they are defaulting treatment. They didn't come to the follow-up, but then after that, actually they went to see the GP because of the shorter waiting time. You need to know also, each time when they go to see a doctor at repast hospitals or at the health clinic, they will spend a whole morning from waiting to get the numbers. After getting numbers, the way to see doctors, go to for blood test will take a few hours. Then they have to go to see the wait for the medication at the pharmacy. So it's not a very pleasant experience for them. Okay. Also, it lead to drug interactions. Also, there will be separate lectures on the drug interactions. So if you're on more than one medication itself, you will see that there is, especially those who have a narrow therapeutic index, need to be very careful of the drug interaction. And also, if you're using multiple medication, it increase the potential ADR, adverse drug reactions. Okay. And we are not talking yet the drug misuse or drug abuse. For example, if they are taking, for example, codeine for their pain, or any of the misuse their analgesic. Okay. So other implications on the health workers, it is also give rise to medication error. Okay, when you have a dispensing error by the pharmacist, if they are taking too many medications, Okay, they dispense the wrong drug. It can be prescribing errors. Okay, drug should be prescribed but not being prescribed, or drug is not needed, is being prescribed. Okay, so all these things were not just causing harm to the patient, it gives rise to medical dispute also. Okay, so overall it will affect the in terms of moral issues and ethics issue. For example, the trust of the patients on the doctors, or the doctors self-perceived job satisfactions. Okay, so on the implications of I have another 10 minutes now. I'll go a bit quickly now. It can give rise to drug resistance, especially antimicrobial, inappropriate prescribing, medication error I mentioned already. Prescription cascade, as I mentioned just now, the previous doctors prescribe 10 medications, and then the next doctor prescribe 10 medication and add on a few more medications. Okay, treatments of circulars. This is, for example, after taking this double antiplatelet, aspirin and clopidogrel, they have this gastric bleeding, and then the doctor had to prescribe the omeprazole, and then they have also gastric reflux. They also add on the antacid. Okay, also the antacid is not well treated again. They are given, for example, ranitidine, okay, which is now is already off market. They can give them, for example, famotidine or H2 antagonist. So this thing is that you are giving more medication to treat the side effect. Okay, how to overcome, minimize from polypharmacy, education, knowledge, informations. Okay, the doctors need to know very well also. This is, for example, the trade name is a big issue now, because there are so many trade names, there are so many combination drugs. So now the antihypertensive used to be one drug, one medication. Sorry, one tablet contain one drugs only, but now they have multiple. You have your endodipine with, for example, hydrochlorothiazide inside. Also, they even add on the statin inside. So they call it fixed dose combinations, and then come with very fancy name. So luckily, with the online prescribing, it can help you to identify, okay, what is the strength or what is the combination drug being used. Because each combination drug, they have, for example, endodipine 5 milligram plus hydrochlorothiazide 50 milligram, and endodipine 10 milligram with hydrochlorothiazide 100 milligram. One combination drug, they have different strength. Okay, it's very hard to keep up with. I mean, so when you prescribe, you really need to know which one is patients on before. Okay, communications, which is again need times and patience. Okay, so there are a lot of new initiative coming out. For example, taking patient medication history, medication reconciliations, medication adherence clinic. So if it's possible, enroll them into this clinic so that it gives times for them to go through their medications. And also de-prescribing, try to reduce the number of medication prescribed to the patients. Okay, let's follow for the next few minutes. Let's go through some cases together to identify, is it polypharmacy, or is it no, or is this appropriate polypharmacy? Okay, so that's this case one. Do you think is it considered as a polypharmacy? And then if not, is yes, or what is the reason? I randomly call some students to give their opinions. Aisha. What do you think this case? Is it a polypharmacy?
I think so.
Yeah, because it is on the overlapping prescriptions, as you see here. This is 14 items prescribed during this period and on the overlap with this same date or overlap with some of dates. So most likely patients is already on 2 sets of medications. And the good thing now with the computerized system, this thing can be avoided because the pharmacy will be able to detect, oh, you're already on this medication before, so they will not dispense again. The doctor will know, oh, you're already on prescribed this medication by other doctors, so I will not prescribe again. Okay. In terms of medication list, is there any overlapping? So if you see here, prochlorperazine, which is if you look at the recall for your pharmacology lectures, is a phenotypes and also is a antipsychotic drug, but we can sometimes being prescribed for as an antiemetic. So most likely this kind of medication, short-term medication used for treating a symptom, for example, allergy, nausea, vomiting, or dizziness, okay, most likely is being prescribed to treat the side effect of some medications rather than the organic problem like patients is having, for example, dizziness. Okay, the dizziness, it could be due to the hypotension, it could be due to the hypoglycemic. Okay, need to be careful. Okay, in terms of, like, for example, ranitidine, in this case, is it caused by the clopidogrel, okay, which can cause this gastric problem? Okay, so need to be careful. The vitamin C, is a patient can taking anti-stomach of if his thinking stomach is quite acidic, he should be taking anti with food. Okay, so need to be careful as well. Furosemide, if you're taking furosemide, it can actually especially it can help to increase the uric acid, is it causing the gout problems for the patients. Therefore, do you need to look into the allopurinol and colchicine for the gout or hyperuricemia? So all these things you need to be checking as well. The psyllium fiber, is it constipations? Any drug that can cause constipations, okay, need to be carefully looking at. Okay, so let's look at the next case. Yeah, this is the summary of case one just now quickly. So the patients have the PTCA or by angiography done in 2004 with a mild left ventricular failure, so multiple comorbidities. So there's seeing multiple doctors and also having pain, osteoarthritis. So need to be very careful, especially with the use of steroid, dexamethasone. So this is a bit small case 2, patient postpartum normal vaginal delivery with raise in the white blood count. Is it sign of infections? Hemoglobin is low. Is it which type of anemia? Okay, vitamin B deficiency anemia or iron deficiency anemia. Okay, need to be very careful. Patients is already on ferrous fumarate. Is it taking patients is take compliance? Is it good? Does it cause constipations? Why you need vitamin C? Okay. So this is the sultamicillin. Again, this is the combination drug. The patient is actually on this unacin. Okay. And paracetamol, is it are they taking any analgesic or not, taking given almost 6 weeks of iron tablets, iron health supplements. Is patient taking any iron supplements on her own? Because if you you can take this they have Sagon Bion, different brand name of iron tablet supplements. Okay, often it have combination with as vitamin C. Okay, so the prescribing, it can be in the ascorbic acid, vitamin C. If it's the dispenser doesn't know, sometimes they're given 2 instead of 1. Okay, so in this case, it's not really considered as a polypharmacy because each one has its own rationales, especially vitamin C, health supplements given to help to enhance the absorption of iron. Okay, but compliance is need to be properly educated. How long the patient need to take the iron tablet? So issue. We have cases of patients taking long-term iron lead to kidney dysfunctions. Also need to be very careful. And need to be very careful. So iron tablet, it look like a brown tablet, look like a chocolate, can cause toxicity to pediatric. Case 3. So let's zoom into this. Patient is on the miconazole antifungus powder and the miconazole plus hydrocortisone cream also, and the non-drowsy antihistamine loratadine. Okay. So main symptom complaint, fungal infection is the groin area and of the face, and then cause itchiness, which is very important in terms of enhancing patient quality of life, because patient is on palliative management. We want them to lead a proper lifestyle before this being succumb to the cancers. So palliative care is something need. They have a palliative care, palliative unit also. Okay, so need to be very carefully managed. The medications. Is it a polypharmacy? You have 2 antifungus, but this is not exactly polypharmacy because the miconazole powder. Sorry for the typo. Okay, miconazole. Okay. The powder one is for them to be applied on the groin area because there's some folding area, and also it helps as a powder as dusting, help them to keep the groin area dry, especially it's very humid or they sweat a lot. And for the face, if they have fungus infections, especially it's very itchy, the steroid hydrocortisone is quite useful. Ask them to apply 1 or 2 times for short-term use. Okay, can help them to reduce itchiness, and also if they have any tinea problem. So loratadine in this case help them to reduce the allergy or itchiness. Okay, it's not considered as polypharmacy even if you have 2 miconazole. Sorry for the typo. Okay, so these prescriptions can be prescribed. Okay. Case 4, let's look at this case. Okay, this is the history. Patient 40 years old, non-hypertensive, already lead to as a heart failure, non-defaulter either, though coming for the clinic, not coming for the medications, because at the pharmacy, they're giving each month rather than giving 4 months. So in a way, it's a good thing because even though it's quite cumbersome for them, they have to go every month to collect their medications. Okay, so not very well. In terms of prognosis, already have cardiomyopathy. First discharge on the 22nd December, and then readmitted again, multiple readmissions with escalating heart blood pressure, meaning that patient is not taking the antihypertensive well, because antihypertensive is very effective. Once you take it, the blood pressure will go down. Okay. So this is their medications list for this one, and then this is the on the multiple, is a repeated overlapping prescriptions. So androlipine, antihypertensive, losartan, you have the non-hydropyridines, calcium channel blockers, you have ARB, you have beta blockers, you have the diuretics, okay, you have the loop diuretics, you have the antiplatelet, you have the proton pump inhibitors, you have your statins, okay. So as you can see, even though you have multiple drugs for the cardio medicines, okay, so this one is they do the de-prescribing, so need to be very checked very carefully. For example, they shouldn't take their furosemide in the evening. If not, they'll keep on going toilet when they sleep, which reduce their quality of life, because cause destruction to their sleep. Spironolactones, very important for patient we have heart failures, taking during daytime. Okay, so here the concern is you need to ask the pharmacist to come in and do the reconciliation, because you're very busy with other diagnosis activities, so you can safely pass on to them. Beta-histines, is it important or not? Beta-histines is prescribed for many disease, for those who have tinnitus, okay, and also used for those who have dizziness. The dizziness, is it because of the patients taking too much or not taking their antihypertensive correctly or not? So when you see this kind of beta-histine for dizziness, so you need to trigger or most likely patient is not taking their medication correctly. Okay, so yeah, the overlap, the prescriptions is considered as a polypharmacy. Any type of clarifications needed? So I'll be sharing, there's one very interesting articles on the polypharmacy which you can read further. If you are interested, you can do your clinical years project on this polypharmacy as well. And as I mentioned, it will not be tested for exam. This is mainly as awareness for your knowledge. Any questions? If not, then we can end today's sessions. Feel free to write to me. Okay. I'll be sharing the video also. So have a good day, everyone. Take care.
Yeah.
Thank you.
Thank you very much.